Medical disclaimer. Please note that the information shared on this podcast is for educational and informational purposes only and should not be considered medical advice. Always consult with your healthcare provider before making any changes to your health regimen, including starting new therapies, supplements, or treatments. While we discuss cutting-edge research and advancements in cellular medicine, individual health needs vary and professional guidance is essential. By listening to this podcast, you acknowledge that neither Dr. Seeds nor the podcast team is providing personalized medical recommendations.
On today's episode, we're going to talk about hormones in males. Hello and welcome back to Redox Revolution with Matt and Maddie.
Hello.
Hello, Maddie.
Welcome back.
Welcome back, Maddie.
Matt, how did my seat feel?
Warm, which
Thank
was
you.
uncomfortable.
I'm so glad to have you back so Matt can't ask me any more questions about myself. Because after those sessions, I was like, you know, Matt, maybe you need to not put this in. And he's just like looking at me smiling. I go, I'm so screwed. He's gonna put some of these things in there. And I let my guard down, but then, you know what? Like I said, I'm old enough, I can take it.
People want to know the real you. They want to know the man behind the bow tie.
This is just me working smarter, not harder. I get asked all the time all of those questions about who he is, and now I'm just
You
going
can
to
just send the video.
I can just send the link.
Yeah.
Oh, you want to know Dr. Seeds? Here you go.
I did that. A patient asked about NAD and what Dr. Seeds thinks. I literally just sent the podcast link.
I love that. Well, that's what these are for, right? Mm-hmm. That's what these are for.
I wish you would have asked me more about skiing and stuff. That would have been fun.
We could have Captain Peptide do a drive-by episode with us where he, is kind of mobile, has his camera, has his little gurney set up. What's it called? Gimbal. It's called a gimbal.
Those gimbals are fun.
As long as he can keep up with us. I know he is pretty slow.
You know he has a new board, right?
Yes, he does.
You think
We were texting about it this week.
he thinks he's a new man because of his new board.
He is. He rips on that thing. But yeah, Drew could record an episode of us while we're going down the hill if he can keep up with us.
No, I don't see that happening.
Yeah, I don't see it either. So let's just move on then
Yep.
to today's
Poor
topic.
Captain Peptide.
I honestly enjoy this part of the episode the most, I think, because he never knows what the topic is, and we kind of just get to hit him with it. Today, and by the way, this is the start of a two-parter.
Ooh.
Today, we are going to talk about low T, what men should know, what they can do about it, and it's a two-parter because next week we will be diving in to women specifically.
Thanks for including us.
Oh, now you're giving me a heads up. Okay, thanks.
Yeah, no, I want to give you that heads up because you may, I know a big point at the Peptide World Congress this year was like, hey, a lot of these protocols have been frameworked around men. And some of the people like Dr. Fitz and Kelly, and they've really been trying to put the word out that, hey, we need to get a little bit more specific in terms of women's health. So we will have an entire episode dedicated to that. So you don't need to dive down any rabbit hole splitting the difference here. We are specifically talking about men today.
Tough job to not go down any rabbit holes. Do you think you can do it?
We're going to see. I guess it depends what he asks me.
So low T in males, also known as
Hypogonadism.
What?
Hypogonadism.
There you go. It can be associated with a wide range of conditions that affect physical health, mental health, metabolic function, sexual performance. These causes and consequences of low testosterone are associated with aging. So how do you first go about approaching these interrelated effects of low T in your male patients?
I'm not really sure where to start with this, but let's just go somewhere.
Ooh, can I say a place where we don't really start with a patient with low T is by giving them testosterone.
And that's a great beginning. So let me go back to what she said in a second, but just I think we due diligence here is to define what's hypogonadism. And today, if we follow the biochemistry of testosterone, it's defined by a number, hypogonadism, and it's typically less than 300 is considered hypogonadal. It used to be 250, then it was now up to 300. So it's defined by a number, but it's typically just if you're defining hypogonadism, and I think we're really doing it a disservice by stating that it's just low testosterone in not producing an adequate amount of testosterone. And there can be primary hypogonadism and secondary. Primary, where there's some type of injury to the testes, it's specific to the testicles, or secondary, where there's some inflammatory process or toxin that's affecting the Leydig cells of the gonads, or something in the brain with the HPA axis. A lot of things can define secondary and primary. But Maddie hit it on the head in really, thank you for starting this off, because I think this is the misconception of, if you think about testosterone, and we know it's produced for males in the Leydig cells of the testicle. The production of testosterone depends on cholesterol getting into the cell, and then then getting into the mitochondria, where it's into the mitochondria,
Powerhouse of the cell.
yeah, and signaling of the cell, where then it's converted into pregnenolone, and then converted into a bunch of other hormones, one being testosterone. So that should tell you right there that if we're in the mindset of cellular medicine, and looking at testosterone production, shouldn't we be looking at why someone isn't producing enough testosterone? I mean, that only makes sense to me. Mm-hmm. And that has always been, I think, how we do things differently and do them very effectively in actually looking at the efficiencies of how that process works, but then also realizing that the mitochondria plays a role, and also oxidative stress or nitrosative stress, can affect the gene activation and production of androgen receptors. So there's receptors that have to work with testosterone, and then there's also the testosterone production. So there's a lot that goes into this, and I think if you're not working on efficiencies of, and so I think it all leads back to the premise of what we're all about, mm-hmm. and that's what it's improving cell efficiency and flexibility. Because if we're making the cell more efficient, we're doing a better job of that cholesterol conversion and to pregnenolone, and then the conversion to the hormone itself. And we've actually, I mean, and I'll stop and let you continue to ask questions, because I need direction on where you want to go with all this. I have a question
too.
And you can ask questions too.
Yeah,
let me finish.
Yeah.
God, I just had a great thought and you stopped me again. It's
you said questions.
All right. Now I forgot. I just think there's so much importance. Oh, we've seen these people that have been on this, this 300 number or 400, and they're told they have low T, and this is the reason. And then we work on root causes. And mm-hmm. what do we see? Improvement in libido, improvement in fatigue, improvement in muscle function, all these things that people, they believe it's all based on this low T number. and it's got so much more to do with she's just waiting to ask this question.
I have like a statement and a question, so two things.
Okay,
now.
I'm gonna stop and let you go at it.
One thing, when you had said the number, I feel like it's important too for people who get like fixated, like my testosterone's 400, it's low, I need to address it. But someone with 400 can feel perfectly fine,
Yes.
not fatigued, still gaining muscle, and then 400 for someone else, they can be feeling it. So it's not
Correct.
about going after the number. You need to go after the patient and what the patient's feeling.
Yeah, and you've seen it. You've witnessed that in our practice and how. And I used to. You remember in meetings earlier, and I catch so much shit from hormone docs who are like, God, you just got to go right at this first. And I'd be like, how does that make any sense? I mean, especially if I want to make things even more effective. You know what? So let's say they do need testosterone and they do need some replacement. Well, I want to make sure I've done everything to increase the density of androgen receptors so I can use less. I want to do everything to prime the system to make this stuff even work better and to use less of it, because we know there are issues with this, and if we get into the discussion, but I really believe that cellular medicine is changing that thought process. It certainly is in women, tremendously in women, more so because of the metabolism issues with estrogen and so forth. But now with males, you're seeing this. We're having patients that are getting smarter about it and are like a little on the fence. Like, do I need to do this? You know what? There's got to be some answers here. So I love that, Maddie, that you've seen that. You've seen it. You've witnessed it. You know it's possible, because you have to work on those aspects of the mitochondria and we can go through. I can go through the mechanisms.
Wait, I have my
some of
question
the-
before I forget my question.
Okay.
So sorry. Okay, so hypothetically, and it might be a dumb question, but it's just how my brain's working right now. Hypothetically, a patient's on statins. Since that like destroys your cholesterol, are patients on statins more likely to have low
You've
testosterone?
seen it. Yes, absolutely. That's so statins, SSRIs, but yeah, low cholesterol absolutely is related to lower testosterone. There's a clear correlation with that, and we've seen it. We can actually we'll go through that as we look at some of our patients here going forward, just so you see that. You just have never correlated it because I've never brought it up, but you asked the right question.
Thank you.
And it's very true. And we see that happen.
So yeah, my next question was just going to be based on some of the stuff you were saying. Let's get into the cell. Like, what are some of the cellular inefficiencies that are leading to this low T production or underutilization of these androgen receptors?
Well, it could be androgen receptor. So it's a multitude of. I'm just reaching, but
Yeah.
it's a multitude of factors that can have an influence on testosterone, and one of them is to remember. Let's define this now. A hormone, testosterone, has to get into the cell, and then it goes into the nucleus to start transcription. Whereas peptides, they handle their signaling through receptors on the membrane. So if we're talking about low cholesterol or low DHA or low plasmalogens or certain phospholipids, those have a significant influence on structure of cell membrane. If the cell membrane is not fluid and it's more fixed and stiff, then it doesn't matter. The testosterone isn't going to get through that membrane and into the nucleus to do its job to activate that androgen receptor aspect of the nucleus. It's not going to happen. So that's why that part is so structure is so important to understand in in influencing the process of the use of testosterone. So that should resonate above all else for everyone. If I can make it clear that, let's say we're going to use testosterone, or we're not going to use it. If we're not using it and there is this membrane issue, if we fix this membrane problem and make it better, then we're helping natural testosterone production get into the cell and do its job, and then we've actually fixed a root cause problem without giving them testosterone. Now, let's say this patient is in a state of where they need testosterone because of some reason from the HPA axis of where they're not making it, or other issues with the synthesis of cholesterol, pregnenolone from cholesterol, or from the enzyme aspect. Let's say, for instance, you need to use testosterone. Well, even if you need testosterone, if it's not going to get through the membrane, or it's going to have a hard time, you're still going to have problems, and that's why you're going to have to use these higher doses that then can have significant negative effects. So that's one issue. The other issue is the mitochondrial issue, which is, I think, the big one, of efficiencies of the mitochondria, where if we're losing the ability to produce ATP and NAD efficiently, NAD is a big part of this process of production from the standpoint that NAD is converted into NADPH, and NADPH is this key cofactor, nuclear cofactor in the production of testosterone.
But getting NAD is not going to increase your testosterone. Just letting people know.
Correct. Good point.
Thank you.
But having the cell do it appropriately. So NADPH is a very significant factor, which is all about cellular medicine and redox. So if they're reactive oxygen species or abnormal, if there's reactive nitrosative species, which is when there's nitric oxide uncoupling, which is another process of inflammation. These all have an effect on the enzymes that are trying to convert the final production of either cholesterol to pregnenolone, or pregnenolone onto testosterone. So there are many steps there where this can take effect. So you've got the issues with the mitochondria, which are, I think, significant. You've got the issues with structure, with cell membrane, and you've got some of these higher issues with the HPA axis, which is the hypothalamic pituitary stimulation to the testes to signal. The pituitary can also be affected by inflammatory problems too. So it's fascinating when you start to look at all of these things, and then you can, and then it's even the transport of cholesterol into the cell itself, not the testosterone into the cell to do its job on the receptor, but actually star protein is something that's important in transferring cholesterol into the cell. That can be disrupted. And so redox plays a role. Membrane structure plays a role. I could just keep going.
Life plays a role.
Yeah, stress.
It can get large, cumbersome, confusing, and it gets even more confusing, right? Because in 2015, if you remember, I'm sure you do, the FDA released a warning statement about testosterone replacement therapy, TRT, and its potential risks
such bullshit.
regarding cardiovascular health. So that was the beginning that started that process of really changing the community's evaluation and understanding of HRT. It sparked a lot of debate. So yeah,
those were poor studies because they didn't. The inception cohort of those studies was ridiculous. I mean, they had people with type 1 diabetes, type 2 diabetes. They had obesity. There were so many other
Wasn't it fair?
It was a terrible. It was one of those things where the media, it's like when they pull a study out and say the world's going to end and it's based on this study. It's the same thing, and it's terrible because testosterone itself, and it's been now that it's been more validated.
And I think that black box was removed, correct?
Oh yeah, it's just been removed this year.
You didn't hear it on the news though.
Of course not. But testosterone itself is as a hormone. Don't let me undersell it. As a hormone, it improves endothelial cell function. It improves mitochondrial function. It improves SIRT function, SIRT protein function. So it improves. It improves anti-inflammatory. It has anti-inflammatory. It works against NFKB.
Can you take all those things that it improves and just bring it down to a very basic level? Because listeners might not know.
Yeah. So in fact, testosterone helps in a physiologic amount, which is what we're talking about, not super physiologic. We're talking about physiologic.
Physiologic is what your body knows how to do with and in range.
How to work with that's in range of normal for people that we've determined normal. So good question. So it actually improves vascular health. It improves muscle function. And that's something. That's a bigger role than we really appreciate because it makes, if you're making good muscle, remember if we go back to working out training.
It's metabolic currency.
Muscles are endocrine gland that are very big in producing myokines. And in fact, irisin and GF15 are very important in the regulation of the HPA axis in helping with testosterone production and luteinizing hormone, which is what activates the Leydig cells to make testosterone. So there's so much there, and this should just keep resonating. That God, why wouldn't you want to look at these mechanisms and improve them before you even jump into this world of, hey, you need this because your number's low? That's insulting.
So let's walk through that process then. How should a patient approach their provider if they want to be treated for low T?
Well, I think they explain their symptoms like they typically do and say, hey, I just want to look. I appreciate this could have something to do with testosterone as a male, but I want to look more into the cellular aspects of what could be contributing to this. And I think that opens the door. That cellular medicine doctor or functional doctor or anti-aging doctor is going to like to hear that, that they want to hear that from their patient because they're like, okay, this isn't another person just coming to get testosterone. This is a person who wants answers.
And maybe they're giving themselves some of the treatment without the treatment. What I'm saying is, we just talked about muscles. What are some of the other ways that men in particular can increase their testosterone naturally?
Exercise.
Yeah, it's all strength training. Yeah, that's number one. You're doing things to enhance the muscle cell to have more mitochondrial density, which is all about making the muscle stronger, but also making it a better signaling agent. Remember, muscle's an endocrine gland. Sorry, endocrinologists, but it's the biggest endocrine gland in the body that produces significant signaling agents. So we want it doing its job to signal the hypothalamus, an area in the brain, to do its job to signal the release of testosterone. So you can't get around that. That's vital. But also keeping muscle healthy is just as important because that's going to keep that axis intact. And I think it gets that simple. And sleep does the same thing. Good sleep helps because you pulse
of the growth
hormone.
hormone.
You'll pulse out growth hormone. You won't lose any pulses, and you'll pulse them out because remember, sleep, if we look at the circadian clock, is the anabolic state of the body. Mm-hmm. It's about recovery, repair. So that's when more NADPH is produced, which you need. It all falls into place. It's that master, the more NADPH, the more anabolic, the more recovery and restoration of all the cells. So it all adds up.
Yeah.
And it's fascinating when you get to look at all of this and you get to go down the road because what do we find? Everybody's different to some degree, right?
And I think it's important for people to know too, like, just because you have low testosterone, a lot of clinics will just be like, here's your testosterone injection. Once you start that, you're kind of stuck to it, or it's hard to get back off of it.
Does TRT need to be continued forever?
If you are doing injectable, pretty much, because you shut off your own production of testosterone.
It's a difficult place to be when you're trying to work backwards when people are already taking injectable, because we find most of them are super physiologic to start with there, and they've gotten used to it. Or that some are in the higher range, and it's hard to get them away from that because it takes I'm going to just say it takes years, if not years, to work on structure, work on really the androgen receptors, because they're desensitizing receptors and messing those up, and they're messing up the mitochondria. It takes a dedicated patient that really wants to do that and it could be less than a year, but to get them off of an injectable and do things, it really takes a dedicated person, because when you do that, you're going to lose right away. It's a hard road because they lose that feeling.
They feel like shit.
Yeah. And so I can do things to get that a little bit better, and I can give them the picture. And we've had a few that stick it out and they end up doing very well. But you have to be, it takes incredible dedication and understanding, and some people just don't have that. They don't want to lose that.
And we've seen too, some people, they try and they really try to push themselves, but it's just not turning back on their own production, no matter what we do. So
we need
go.
We need more time, and they just lose their patience. And I understand that. And so then you've got something you got to work around, which is what we do. And so it makes it very interesting with all of these, with all the different ways you can do that.
So what are your thoughts about Enclomiphene?
Enclomiphene, good.
Maybe describe what it is first and what your thoughts are on it.
So Enclomiphene is actually a SERM. It's a selective estrogen receptor modulator. And what does that mean? Well,
it modulates selective estrogen receptors.
Correct. Thank you. and it works in a way where estrogen is something that actually works in it inhibits. It can inhibit the release of gonadotropin releasing hormone. And so as Enclomiphene is a citrate, and there's Clomid, which is another SERM, but Enclomiphene is just a little more refined, and it works. So it works by disinhibiting the gonadotropin releasing hormone, meaning it makes it work better. And so you're influencing more, the pituitary is influencing more of the Leydig cell to...
what is the Leydig cell?
It's a cell in the... there's the Leydig cell and the Sertoli cell. The Sertoli cell that... Leydig cells concerned with making testosterone, and the Sertoli cells were about spermatogenesis.
Okay.
And so luteinizing hormone it's released and influences testosterone production, and FSH, it influences the production of sperm and spermatogenesis. And so enclomiphene citrate's a little bit better in the fertility side of improving FSH. But it also, what they do is they just let the bottom line is Clomid and enclomiphene citrate. What do? They work on helping you produce your own testosterone. So it's a step in a direction of trying to let you do a better job with testosterone based on your own production without introducing an exogenous source.
So what about HCG? What's the difference between like HCG and enclomiphene citrate?
So HCG is another way to influence the luteinizing hormone and FSH. It's more luteinizing hormone. It's more of production, and it's just another. It's another potential way to improve that release of the pituitary.
So it doesn't cause like any negative feedback like testosterone does. It doesn't shut any of your body's own production off.
No, but it can. No. So you have to be. It's one of those. There's definitely an art in using it, and how much to use it. It's all about improving testicular volume and actually, helping in your own production of testosterone. And it works differently in different people, but it definitely has its role for people that prefer to use something like that. It's more of a bridge. I think it's more of a bridge than enclomiphene or Clomid in people that have maybe had to go on testosterone and are trying to get back off of it.
Well, I notice a lot of clinics, like when looking up where patients go, I'm nosy, so I look up the clinic to see what they're all about. And they'll do like courses of like 6 weeks of testosterone and HCG together. And then maybe one day a week they'll add in an anastrozole. But then they stop for 4 weeks and then they'll do it again. But the HCG is always with the testosterone.
So what they're doing is they're trying to maintain testicular volume and to try while you're causing that negative feedback with the testosterone
To keep your testes.
to keep your testes still producing. And so it's a way of cycling and continuing to be able to use all of those together. And the anastrozole are the people that produce
Estrogen,
more,
right?
that convert more estrogen. So convert testosterone to estrogen, and that's to lower that aromatase enzyme that does that. And
Is it good to do cycles like that though?
I think the people that do it that way, it's just my opinion. You're going to find out there are 5 million experts out there about all of this, right? My approach is just cellular medicine. Let me give you the facts. Think about it, and I don't think you can argue the approach we take at all.
No.
I like the cycling that the people use there because they're being responsible. They're not trying to desensitize androgen receptors. So and they're different styles of cycling. But I really appreciate those people are really trying to do it right, and that's keeping the testicles working in producing their own hormone. And so sometimes you'll see when you put people on something like that, and hopefully when they're doing that, they're doing the things we do to work on improving mitochondrial function, and then seeing when they get off of that and go back, when they stop the testosterone and go to try to live on their own production, they do it well and they do it better, and then they don't have to go back on it.
So what's the length of time that they could be on a cycle before it's like your receptors they're toast?
Oh boy, that's a debate. That's a circle debate.
Struck a nerve with that one.
Well, there are, again, so many experts that just think, well, I think you can be creative with that. I think the time frame you can, the people that do the 6 weeks and 4 weeks off, or I think you can go longer. I think the androgen receptors, it all depends on what you're doing, because nobody knows unless you're actually testing and doing biopsies to look at androgen receptors and looking for real deficiencies of the gene transcription, all the things that you potentially could do.
Yeah.
It all depends on that. And so it could be a multitude of cycling to make that happen, right?
Fair answer.
6 weeks, 3 months. But if you're working to make things better, it's going to get better. And then there's people that you aren't, and I think that's what most, unfortunately, these clinics that are just set up to give you your,
testosterone.
They take a number, they give you the testosterone, give you these other things right away, but they're not doing anything to correct anything. And I think people are looking for that, but you're doing a great disservice to your body. We're doing a great disservice to medicine, and to the holy grail of the cell of, hey, why not work on improving things before or during that if you choose to go that route. So I think we touched on a lot here, because we could go, and I think we'll have to dedicate another episode to actually the treatment side.
Yeah, like how can you help someone with low T?
How can you approach this low T? Because we have more options than we've ever had, and now especially with this oral, the oral type of testosterone that we've been working on for 20 years to make it available where it's healthy. And it actually follows a half-life, and
it's processed through your lymphatic system, so you don't get the liver toxicity.
Yeah, exactly. And so those are things that I think would make a great episode to follow this at some point if we can remember.
Yeah.
Because we should spend the time on that to talk about the options, but also talk about the peptides and things we can do to make that work better if we need to, but maybe not even do that. So I really like what you picked out today, because there's so much to this that we need to be more. I feel we just need to be more responsible in improving the discussions that we have with our patients, so they truly are given all the options, and they can make an intelligent decision on where to go with this. So again, we've got a lot to discuss. This was a great topic. I really am enthusiastic about where we're going to go with this. I'm even looking forward to next week now. And I want to just, thank you everybody for being part of this episode. Again, Matt and Maddie. Maddie, some good questions again, and way to follow up and fill in.
Thank you.
And Matt, way to pronounce Enclomiphene.
Yeah, right.
That can be a tough one.
Nailed it.
And actually,
oh boy.
Actually, now that I'm thinking about it, we should bring up SARMs also in the next, when we do this discussion about, because I've done a video on that I think people should look into on the selective androgen receptor modulators, because those are big in young people, and we see
And they fuck them up.
yeah, Maddie said it. We see a lot of bad things there. Thanks again for being with us on this Redox Revolution episode. As I already thanked Matt and Maddie, I will be back.